Dear viewers, we would like to present the use of the TAPP technique, known as a preperitoneal dissection and placement of a synthetic mesh, to repair a postoperative hernia in the epigastrium. We operate on a 66-year-old patient with a BMI of 34, who underwent cardiac surgery 11 years earlier. As you can see in the picture, the defect is located between the costal arches, just below the xiphoid process of the sternum. This is a difficult location to access using an anterior approach, so we decided to perform a laparoscopic approach. A 10 mm optic trocar was inserted in the left mesogastrium, slightly medial to the anterior axillary line. The remaining two 5 mm trocars were inserted approximately 5 cm from the optic, which allowed for good triangulation of the instruments in the operating field. It is also helpful to bend the operating table dorsally to avoid collision of the left instrument with the patient's thigh. Then, approximately 8 cm from the midline, we will incise the peritoneum and separate it from the anterior abdominal wall to create a large space for mesh placement. Pneumoperitoneum is obtained by inserting a Varese needle at Palmer's point. After inserting the optical trocar and ensuring its safe penetration through the abdominal wall, we reduce the pneumoperitoneum from 14 to 12 mm of mercury. Then we assess the hernia itself, paying attention to the presence of adhesions, the contents of the sac, the quantity of fatty tissue of the surrounding tissues, the possibility of reducing the sac inward, and the condition of the peritoneum around the defect. Using the factory inscriptions on the instruments, we measure the distance of the peritoneal incision site from the midline. In this case, the peritoneum will be incised at a distance of 8 cm from the midline, and we mark this distance with cauterization points on the peritoneum. It seems that the most difficult step of this operation is initiation the dissection in the proper layer. We warn you that the beginning of separation of the peritoneum is difficult, laborious, even irritating, and requires a lot of patience, attention and smoothness in the use of tools from the surgeon. To make the dissection of the peritoneum a little easier, we ask the assistant to slightly press the linea alba in the upper abdomen with the fingers of his right hand, thus obtaining a more favorable angle for grasping the peritoneum. It is also worth paying attention to the instruments used. At this stage, it is beneficial to use a dissector because it allows us to grab the edge of the peritoneum quite precisely. At a later stage of the surgery, it will be necessary to replace the dissector with an atraumatic grasper because the tip of the dissector is too sharp and may damage the peritoneum. Notice how quickly and relatively easily we get under the diaphragm, almost to the area of the tendon center of the diaphragm. Once we reach the place where fatty tissue appears under the peritoneum, dissection becomes much easier. At this stage, you still need to be gentle in the dissection. You can now use coagulation to stop the bleeding somewhat freely, without fear of damaging the thin peritoneum. The general principle of dissection is to leave all the fatty tissue down, and on the roof we should have the posterior laminae of the rectus muscle sheaths and the linea alba. That means we move just below the white cohesive fibrous tissues of the fascia. Only when we have dissected the space on the sides of the hernia defect can we start dissecting the hernia sac. At this step, we use quite strong traction, sometimes external pressure, as well as blunt dissection combined with sharp release of individual fibers holding the hernia sac in the subcutaneous tissue. It is worth paying attention to the extremely stretched fibers of the linea alba around the defect, known as a diastasis recti of the abdominal muscles. This means that an attempt to close this defect using an anterior approach using only sutures would prove ineffective. Finally, the edges of the defect became visible, much wider than they originally appeared. At this stage, all we need to do is cut off the remnants of the sac from the edge of the defect and we can start dissecting the peritoneal flap on the opposite side. Preparing the opposite flap is easier because the weight of the released fatty peritoneal flap provides additional downward traction. We dissect at a similar distance on the opposite side as proximally. Also note the conglomerate of adipose tissue left at the top, directly adjacent to the linea alba. This is the xiphoid process of the sternum, under which a mesh will be placed to provide additional support. To avoid the mesh from moving inside the defect, we close the hernia defect with a continuous suture using a non-absorbable, self-locking suture of size 0. In the case of smaller defects, a laparoscopic suture passer can be used, while defects below 1 cm do not require suturing at all. After making several passes with the needle, we gradually tighten the thread, gradually bringing the edges of the defect closer. At the same time, we avoid plication of the diastasis recti itself. Maintaining traction on the last thread with one of the instruments, we grab the next weave and gradually tighten it as well, swapping the tools we use to grab the thread. Finally, we can measure the space where the mesh will be placed. For this purpose, we use a sterile paper ruler, which we cut to a width of 5 mm so that it can later be pulled out through a 5 mm trocar. We see that the caudal margin of the dissected space is 10 cm, similarly cranially under the xiphoid process of the sternum and the diaphragm. Laterally, we obtained 8 cm on each side. Therefore, for the current defect, which we estimated at 4 cm, we use a mesh size of 20 by 16 cm. For these operations, we usually use heavier and stiffer meshes, but still macroporous. With such a large mesh size, there is concern about its inadequate placement. Hence, before inserting the mesh into the abdomen, we placed a suture in its central point, which we then pull outwards using a suture passer. Thanks to this, we are sure that the center of the mesh overlaps the center of the defect being repaired. All that remains is to unfold the remaining circumference of the mesh so that it lies flat against the fascia around the hernia. Then we close the dissected space. We use a self-locking absorbable suture in size 3/0. To avoid tearing of the peritoneum, we use mattress suturing on each side. Strong rotation of the needle holder after each passage makes it easier to grab the needle by the dissector and prepare the needle for the next move. After closing the peritoneum, we additionally unfold the greater omentum so that it is right below the suture line we made. Finally, we insert a suction device into the suture line and desinflate this space, allowing the peritoneum to adhere to the mesh and immobilize it in this space. Thank you for watching this material, and we encourage you to watch other videos on this channel.